Şimdi anksiyete bozuklukları çocukluk döneminde en sık görülen psikiyatrik rahatsızlıklar arasında, biliyorsunuz yaklaşık %10 ile %20'lik bir prevalans veriliyor, yaşam boyu prevalans veriliyor çocuk ve ergen yaş grubu için. Oldukça sık görülen problemler ve işlevsellik üzerine de
So it's a common problem of children, and there's also a significant functional impairment, both the functions of the child as well as other individuals who are in the same social environment as the child. Academic disorders in the long term may also precipitate other types of anxiety disorders as well as depression, substance use, as well as suicide attempts, and they also have an impact on academic performance, and therefore it is important to identify the anxiety disorders and to manage them. But about the management of anxiety disorders, although this is important, we only have limited data. As of today, so we don't have an SSRI or SNRI that has been approved by the FDA for the treatment of anxiety disorders. However, in the last decade especially, our knowledge has deepened, so our hands got stronger. I think the most important study on this was conducted by Volkart and his co-workers. It's called treatment of childhood anxiety. So it's a combined analysis of patients with different types of anxiety disorders, and cognitive behavioral therapy, sertraline, or a combination of the two are separately investigated. If you look at the study, the majority of the participants have 2 or more primary anxiety disorders, in around 36%. All of the 3 targeted anxiety disorders criteria are met, so the mean age is around 11, and the number of female and male participants are roughly equal. Both monotherapies, CBT as well as SRT, are significantly more effective compared to placebo. There is no significant difference between the two. In contrast, combination therapy is more effective than both therapies alone. So when you use CBT in combination with sertraline, it is more effective. The efficacies in combination therapy, the effect size is 0.86 for combination, 0.31 for CBT. This is something that the dosage is not something that we are used in our clinical practice. In the sertraline group, 146 milligrams per day were used. And in the group that are on combination therapy, the average sertraline dose is 133 milligrams per day. So we have to ask the question if sertraline is safe at that dose and whether there are any side effects in that population. Apart from sleep problems, in the group who is on sertraline, there is no significant adverse effects in comparison to placebo. So what are the baseline characteristics of the patients which are positive predictors for the response to the treatment? The younger age, that they are non-minority, that the baseline anxiety severity is low, that there are no other internalizing disorders such as anxiety and depression, and absence of social phobia are associated with a more positive prognosis. Of course, after the 12th week, there's even an extended follow-up, and even until the 24th week, the placebo group is eliminated, and the response rate keeps on increasing until week 24, and combination therapy is again superior to the other treatments alone. More than 80% of the initial responders continue to respond to the treatment even at weeks 36. And recently, 6-year results of the study have been published. And if we look at the results, we see that for such a long follow-up, 6 years is quite a respectable number. And 59% of the original sample size is being followed up and still included in the study. Almost half of the subjects exhibit remission in terms of anxiety disorders, and response to initial treatment is a positive predictive factor with an odds ratio of 1.83. At the end of year 6, what are other positive prognostic factors? In terms of revision, if there's a good family functioning, and in the male sex, we have a high rate of remission. In terms of anxiety severity, initial responder status, and then again, male sex is again a positive prognostic factor, and baseline response status, that the absence of externalizing comorbid disorders and fewer negative life events and absence of interim medications and therapy use are associated with a better global functioning. Of course, the data are not limited to this study. This is an older study that was done using fluvoxamine. Again, the sample size are subjects with social phobia, separation anxiety disorders, and generalized anxiety disorders. Only 128 patients have been included in this study, and we also have favorable rates here. And you can see the response for fluvoxamine is 76% and 29% for placebo, and the effect size is even better with 1.1. Fluoxetine, and this study addresses the use of paroxetine in children and adolescents with social anxiety disorders. In both in children as well as in adolescents, there is response to paroxetine treatment. However, in the group on paroxetine, although it's not statistically significant, in 5 patients, an increase in suicidal ideation has been reported, and no such problem has been reported for the control group, and therefore we should be careful when we prescribe paroxetine. This is a therapy, fluoxetine, in the background of CBT. Compared to placebo, it is more effective for social phobias, but cognitive behavioral therapy appears to be higher than, more effective than fluoxetine. CBT's effect, especially after week 8, increases. In addition to SSRIs, SNRIs effectiveness has been studied as well. Here we see this study looks at the effectiveness of venlafaxine in the treatment of generalized anxiety disorders in children and adolescents, and there's 69% of response in the venlafaxine group. There's only 48% response in the placebo group. If you look at children and adolescents, in both of the groups, we see that there is a benefit from the treatment. However, in the children, the benefit seems to be a bit lower than compared to adolescents. Is the use of venlafaxine safe? We know that it's efficacious, but in terms of cholesterol levels, pulse rate in the systolic and diastolic blood pressure, and there's weight loss and decreasing height increase. In this regard, maybe venlafaxine is an efficacious treatment, but about its safety there are still some question marks. And about suicidal behavior, there are some case reports that with an increased suicidal ideation, but there's no systemic effect. Again, the effect of venlafaxine in social anxiety disorder has been studied too. This is a rather large sample size. Again, in social anxiety disorders, we see that the patients are responding to venlafaxine. It's 56% versus 10% in the placebo group. Again, we have side effects such as anorexia, and about suicidal thoughts in 3 patients. 3 patients who are on venlafaxine reported an increase in suicidal ideation versus 0 in the placebo group. It's again not significant statistically, but similar to the paroxetine, we should be a bit more careful in terms of suicidal ideation when you prescribe venlafaxine to a patient. Another SNRI, this was published in the Orange paper quite recently. Again, in children and adolescents with generalized anxiety disorder, duloxetine was studied both in terms of response remission and functional remission. There is a significantly better effect with this drug compared to the placebo group. If you look at the adverse effects that are associated with duloxetine, we again have an increase in pulse, decrease in weight, as well as palpitation are among the side effects that are reported in the drug group. Because we are discussing innovations, we don't have a lot of novel drugs here, but this is one of the most recent studies that are published, as far as I know at least. Here, clomiphen, fluoxetine, and placebo have been studied in the treatment of individuals in children and adolescents with anxiety disorders. Clomiphen is not significantly more effective compared to placebo, whereas with fluoxetine a significant effect could be demonstrated. In general terms, you can see all the randomized controlled trials that have been conducted in children and sizes. This is the effect size. The average is 0.62, and you can see the distribution here. Sertraline and fluoxetine have been reported to have a significant effect size in many studies. This is a review paper, and the result is the molecule that is used, its affinity to sertraline transporter mechanism. If the different molecules are compared, and the higher the affinity, the better the effect size. It's of course not possible to draw definite conclusions, but maybe we may want to keep this in mind. More serotonergic agents appear to be more efficacious. And how does this effect come about? We have only limited data. This is just one example I would like to share with you. This is quite a small sample size. Only 7 patients received CBT, and the increased activation in VLP-PFC in both groups with CBT as well as controls. There's a correlation with improvement has been established about the effectiveness of different drugs in different conditions, whether biological markers can be of use of it. There is at least some hope according to the results of this paper. So children with depression and anxiety disorders have been included in this study, and the total sample size is 83 SSRI. Citalopram has been initiated in those patients. The response rate is 60%. Tryptophan, hydroxylase, and serotonin transported. If the subject had those alleles, the response rate is 80%. And if not, it's only 31 group. In the heterogeneous group, the response rate is 67%. So, of course, we have to study this effect in more detail in future studies, but this is, of course, certain biological markers can give us an idea about the effect of certain drugs in some conditions. In anxiety disorders, in the first line, SSRI is used. And here, fluoxetine, sertraline, and fluoxetine give us a stronger hand in this regard. And in non-responders, maybe a second SSRI, or depending on the clinical condition of the patient, and subject to closer follow-up, SNRIs may be used. About benzodiazepines, because we are discussing innovations, we don't have a lot of novel drugs in this group, but in terms of their safety, we have new data in patients with anxiety disorders, especially in patients with prominent aggression, and especially if they also have suicidal ideations. We have to be careful when we use benzodiazepine, because there may be an increase in suicides among those patients. So we may use benzodiazepines in those patients, but we have to be extra careful, and we have to closely follow up those patients. Thank you very much.